So my talk is going to look at using neuromuscular electrical stimulation and blood flow restriction and how we can utilize these to optimize healing in the acute muscle injury phase. So will my slide work? Good, okay. So first off, a little bit about muscle injury healing physiology. So broadly speaking, muscle injuries, they follow a three-step course of healing. So this is destruction, reparative, and remodeling. And I would strongly recommend everyone to read the papers by Jarveen in the bottom right-hand corner. They'll go into this in a lot greater detail than me. So first off, we get the destruction phase that takes place. So with it, oh, sorry, I was going to turn these notifications off. So, sorry, everyone. Oh, God. Okay. Okay, we're back. So first off, there's a destruction phase that takes place. So here we'll get rupture and necrosis of the myofibers. We'll get a formation of a hematoma, and then an inflammatory cell reaction will start to begin. So if we go into this a little bit more detail, so at day 2, the necrosed or dead parts of the myofibers are being removed by macrophages, while the formation of the connective tissue scarred by fibroblasts has begun within the central area where the injury occurred. So after acute muscle injuries, there's an immediate protective phase that should take place. And research shows that immobilization immediately after muscle injury will prevent excessive scar formation. And also active mobilization immediately after injury, even if pain-free, has been shown to increase the risk of recurrence of injuries to the original site. So it reinforces not only a protective phase, but definitely a brief period of immobilization, even after muscle injuries as well. So currently we recommend at least 2 days, just because of these healing processes that have only just begun. So then we get on to day 3. So here satellite cells have become activated within the basal laminar cylinders. Day 5, myoblasts are fused into myotubes, and the connective tissue in the central zone has become a lot denser. Day 7, the regenerating muscle cells extend out of the old basal laminar cylinders into the central zone where the injury took place, and they start to begin to pierce through the scar. Day 14, the scar of the central zone is further condensed and reduced in size, while the regenerating myofibers close the gap. And at day 21, the myofibers are virtually fused with little scar in between. So what are some of the issues that we get after muscle injuries, like long-term? So there's research showing that we get long-term reductions in muscle strength. So this is especially eccentrically in hamstrings as well, and that's the graph on the bottom right. We see reductions in muscle size, but we can also see neuromuscular inhibition and voluntary activation deficits. So neuromuscular inhibition, a reduced ability to make voluntary contractions of muscles, is a common problem after injury, even though there is no damage to the innervating nerves. And muscle weakness after injury can be partly explained by atrophy of the muscles, but also by the decreased ability to activate the available muscle fibers and motor units. So this is known as voluntary activation. And additionally, spinal reflex activity from swelling and pain may also alter efferent motor output that reduces muscular strength, with all of these contributing to an increased risk of re-injury. So, can we use neuromuscular electrical stimulation and blood flow restriction to enhance our muscle healing, and should these be included in the current police acute management paradigm? So first off, what is neuromuscular electrical stimulation, or electrical stim for short? So it involves the application of electrical stimuli to superficial skeletal muscles, and this triggers muscle contractions, which you can see here. And it does this by activating the intramuscular nerve branches. So electrical stimulation has been attempted in cases where there is inhibition after injury due to its ability to induce action potentials in the motor nerves and override inhibition. So a little bit about the mechanisms of how electrical stimulation works. So I hope you've had your coffees today. So Briefly, it has a unique recruitment pattern of motor units and compared to voluntary exercise, where it will recruit both slow twitch and fast twitch fibers, even at very low force levels. So like I said, this is different to voluntary exercise that follows Henneman's size principle. But with electrical stim, we can get both slow twitch and fast twitch fibers pretty much instantaneously. And the research shows that increases in strength induced by electrical stim training, they seem to be mainly mediated by increased neural drive and motor unit recruitment. It's very neural-based treatment. And the fact that electrical stim and voluntary exercise have different motor unit recruitment effects should be used as a key point motivating the combination of both forms of treatment in terms of neuromuscular rehabilitation. So next up, what is BFR, or blood flow restriction training? So basically it's when partial occlusion is applied to a target limb, and it's either with or without exercise. So a cuff, an inflatable cuff traditionally, is going to be at the most proximal part of the leg. Well, for us, yeah, it'll be the thigh as we're working the leg, but it'll be the arm otherwise. And you want to work at pressures between 40 to 80%. So this is arterial occlusion pressure, also known as limb occlusion pressure. So I'll talk about these in a bit more detail later on. So blood flow restriction training, it is safe, done properly, has the same adverse events rates as traditional resistance exercise. The basic premise of it is that we can use low intensity resistance exercise, combine it with the blood flow restriction, and we can get the same adaptation as high intensity resistance exercise. And there's also no added benefit of BFR when you go in heavy with it. So anything above 50% 1 rep max, if you add blood flow restriction, you don't get no added benefit in muscle adaptation with it. So how does blood flow restriction work? So broadly speaking, BFR reduces the mechanical tension and amplifies the metabolic stress to produce muscular strength and hypertrophy gains similar to high intensity training. And although the exact mechanisms behind BFR remain unknown, greatest consensus globally alludes to the indirect effect of metabolite accumulation and the hypoxic environment, causing greater muscle activation, fatigue, and anabolic signaling compared to the same intensity of exercise without BFR. And the accumulation of metabolites induces neuromuscular fatigue through the stimulation of group 3 and 4 afferent fibers. And therefore, for the muscle to maintain force output, higher threshold motor units are recruited quicker, resulting in a hypertrophic stimulus for a greater proportion of muscle fibers compared to the same low load of exercise without BFR. And additionally, the localized hypoxia that is caused by BFR is shown to stimulate muscle growth by activating muscle satellite cells and angiogenesis. And this is via the proliferation of vascular endothelial growth factor. So all those important, especially for muscle healing. So the police paradigm, the first P is for the protection phase. So as I said before, would recommend at least 2 days of mobilization immediately after all muscle injuries. So the issues that we get in these periods of mobilization, as sort of Martino spoke about earlier, is that we get quite sharp declines in muscle mass and strength of up to 0.5 to 2% a day. So because of this, researchers have applied blood flow restriction and electrical stimulation both passively during these periods of immobilization. So if you look over to the graphs on the right, they both have similar effects in being able to reduce the amount of atrophy that's occurring. As if it's sunny. They're both able to reduce the amount of atrophy that's occurring. However, electrical stimulation on its own has a slightly better effect at sort of maintaining the muscle mass, but also it has a better effect at maintaining the strength. So whereas when we apply just blood flow restriction on its own, passively, it's not able to reduce the amount of strength loss that we see during these periods. So electrical stim is slightly better. So more interestingly, well, for me and hopefully a couple of you, is in a systematic review. So this was a basic science research using crush and stretch-induced muscle injuries in animals. And they found that electrical stimulation applied immediately after muscle injury was able to reduce edema formation So this review is from Schneider in 2010, and Burgess found slightly similar in ligament injuries as well. But Schneider state that from a physiological standpoint, edema formation post-muscle injury is related to an increase, is related to a leakage of plasma proteins in cell membranes into the interstitial spaces after injury, and this results in an increase in fluid accumulation into the affected area, leading to swelling. So it is theorized that electrical stimulation immediately after muscle injury, it minimizes the leakage of plasma proteins by limiting microvascular permeability, and it increases the rate of plasma protein uptake through lymphatic channels, leading to reduced edema formation. So if we're looking at acute management of muscle injuries, so we want a period of protection so we can immobilize them straight away, but straight away we can also apply electrical stimulation to not only prevent atrophy, but we can reduce inhibition and we can reduce edema formation. So next up, the optimal loading part of the police paradigm. So this is where I would recommend utilizing BFR to sort of maximize the muscle adaptations that we can see. But how can we do this? So first up, blood flow restriction combined with aerobic exercise. So this has namely been done with walking and cycling. So it has a few studies supporting its use. So firstly, when we walk with BFR, and this is really slow speed as well, that we see significant changes in muscle strength and muscle growth. And as you can see in the top right-hand graph, this is pretty linear change with a daily intervention of it. Whereas walking on its own, we didn't see any changes in muscle strength or size with this. So a similar effect happens when we add blood flow restriction to cycling. So again, relatively low intensity, 40%. So here we can, So here, if we add blood flow restriction to cycling, we can get significantly greater changes in muscle strength, muscle size, but also in VO2 max, as seen in the bottom right-hand corner as well. So when we're looking at aerobic exercise, we can increase the muscle adaptation when we're adding BFR, but not only that, we get greater changes in VO2 max. So now blood flow restriction combined with resistance exercise. So this by far has the most research supporting it. I think upwards of 250 studies now when I last looked. So we can say that it works. And there's meta-analytical data showing that when we're at a very low intensity resistance exercise, so between 20 to 40%, one repetition maximum, if we add BFR to these, we get greater benefits in muscle strength, hypertrophy, and there is evidence for architectural changes, as spoke about by Martino as well, compared to the same low load of exercise without BFR. And furthermore to this, there is proximal effects on muscle growth. So we actually see changes in muscle growth above where the cuff is located as well. And clinically, when I'm applying this, I pretty much use it on everything below 50% one repetition maximum. So now electrical stim combined with BFR. So like Mike said, this is what the focus of my PhD. So get all your bias hats on for this. So there is emerging but mixed evidence currently for combining electrical stim with BFR. So we've got 2 human studies and 3 animal studies showing significantly greater improvements in muscle strength and size compared to electrical stim on its own. And this has been done in healthy and clinical populations as well. So the training study we've got going on at the moment, which is obviously paused because of what's going on. So we're 3/4 of the way through data collection, and we're finding 2, if not 3-fold, great changes in muscle strength and hypertrophy. But obviously, yeah, we'll be studying this a lot more detail coming years. But one thing I would say is when we're looking at acute muscle injury management, we don't know what the combination of electrical stimulation and BFR has on edema formation, as I sort of touched upon earlier. So if we're looking at acute management of muscle injuries, I just apply electrical stimulation just on its own for 2 lots of 20 minutes daily. But when reducing edema is not a treatment goal of myself, then I would combine the 2, looking for sort of greater muscle adaptations. So a couple of other little pointers for blood flow restriction. So this study was by Pseudo, another animal model, where they applied eccentric exercises and they either had with or without blood flow restriction. So they were able to show significantly greater enhancement of muscle protein synthesis rates without muscle fiber damage, with significantly less muscle fiber damage than the eccentrics just done on their own. So this may be advantageous when first introducing eccentrics early after muscle injuries to hopefully get all the benefits without the negatives. And this is how I use it as well. So blood flow restriction effect on pain. So there's a lot more interest in this the last few years, and my supervisors are sort of leading the way, but doing a lot of work into here. So a few studies now are showing that a single blood flow restriction session, it can acutely reduce pain for up to 24 hours later. So they've seen this in patellofemoral knee pain and patients after ACL reconstruction as well. And what they've found is sort of one of the mechanisms behind this has been the endogenous opioid production of beta endorphin. But not only have they found acute reductions in pain to the exercising limb, but they've also found this on the other side as well. So if we're looking at using blood flow restriction during this optimal loading part of the paradigm, when we're looking at everything low intensity, we can get greater changes in muscle strength, hypertrophy, hopefully reduce the muscle damage associated with eccentrics, and acute reductions in exercise-induced pain as well. So now I'm just going to go through the methods of how to appropriately apply electrical stim and BFR. So first off, electrical stim. So a key point with electrical stimulation is the amount of intensity or the current that goes through the electrode into the muscle is going to equal sort of greater muscle adaptation, which makes sense. The amount of current in, the greater the adaptation. And that is shown on the graphs on the right with a higher intensity current groups sort of having greater changes in strength and hypertrophy as well than the low intensity current groups. However, if you've ever had it, if you're increasing that current intensity, it leads on to the main issue with it is that it is painful. So increasing the electrical current going through, it makes it more painful for the person. But if we're aiming to get the most current into the muscle possible, how can we do that by reducing the pain? So first off, we can use larger electrodes. So the evidence suggests that anything above 19 centimeters squared now helps to reduce the discomfort associated with it. But the most important thing is by locating the motor points on the muscles. So this is one thing I just don't see anyone doing if ever I speak to them or I consult to them about it. But this is the main methodological point for electrical stim training. So to further reiterate the point of why locating motor points is important, so the figure on the right, that was from Gobbo's study in 2014. So they applied the same amount of current through an electrode that was either placed on the motor point or away from the motor point. And as you can see, when it was placed on the motor point, there was significantly greater torque produced, had greater blood flow, muscle oxygen consumption, and significantly less pain than when it was away from it. So all of those factors add up to greater muscle adaptation and more clinical effectiveness when you're applying them. So if finding motor points is important, how do we do that? So I've got a couple of little YouTube videos in the next couple of slides, just because all my gear is sort of locked away at university. But this quick one from Compex just shows how to locate motor points quickly. So hopefully.
Sorry, Paul, are you able to do a bit of a voiceover? We're not getting the sound through.
What was that, sorry?
Are you able to do a bit of a voiceover as we're not getting the sound through?
Oh, okay, sorry. So I'll play it again. Yeah. Please getting the sound. So basically, you apply the electrode jet, like ultrasonic gel, over where you want to apply the motor, where you think the motor point is located. You have an electrode on that muscle, and your device will have one electrode on, well, one probe on the electrode, and then the other on the motor point pen. And basically, you move the motor point pen over the muscle, and you're looking for the greatest twitch response when you're doing it. Basically, when you're on the greatest twitch response, that's when you know you're on the motor point, as you can see there. Whereas when you're off of it, there's sort of no twitch response. So then once you find the motor point, you can sort of mark that, and then that's where you're going to be placing your electrodes onto there. For the greatest sort of motor unit recruitment, but the significantly less pain that we sort of spoke about a bit earlier. And a couple of other little pointers for finding motor points is the length of the muscle will affect where the motor point is located. So if you are changing the joint angle, anything like that, just know that that's going to change where the motor point is located on that muscle. And worse comes to worse, if there's no sort of motor point set in and there's no way of sort of creating your own on your device, then the figure on the right is from a study by Botter, where they mapped out the motor points in the quadriceps and the calf. So as a bare minimum, that's a good reference point to know where to place the electrode. But I would recommend that you can either get a device or create your own setting in yours to find motor points, because it will significantly enhance your treatment effects.
5 minutes, Paul, as well.
So, what was that, sorry?
5 minutes.
Okay. So blood flow restriction methods. So the main thing on blood flow restriction is we want to determine arterial occlusion pressure, also known as limb occlusion pressure. So before I apply it, I clear them of the contraindications on the right. And what I do is I measure their blood pressure and their ankle brachial index, which uses the same equipment for measuring arterial occlusion pressure. So basically you have the inflatable cuff. So for us, it'll be at the top of the thigh, and you'll have a handheld Doppler, and this will go on the posterior tibial artery behind the medial malleolus, and you inflate it until there's no pressure going, until you can't hear a pulse on a handheld Doppler. So I would show you that video, but it's only the sound that I was worried about, so I won't bother with it. But basically you have the cuff placed, you get you yourself or the patient does it, you inflate the cuff until you don't hear any pulse on the handheld Doppler. Then you know that's their arterial occlusion pressure. And then from there, the reading on the strain gauge, or the pressure reading it gives you, that's what you use to prescribe your restrictive stimulus. So what are the current up-to-date evidence-based protocols for both? So electrical stim for muscle. So frequency, we're looking at 30 to 50 hertz. I use 50 hertz. Pulse width, 3 to 400. I use 400. Contraction time, 3 to 6 seconds. I use 5 seconds. Work to rest ratio of 1 to 1 to 5. I use 1 to 1. Duration of 6 to 40 minutes. I use 20 minutes, and I do 2 lots of 20-minute sessions. And the intensity I use is max tolerable. And the key point again is you want to be finding the motor points in the muscle. And found out that first paper on PhD got accepted yesterday, which I'm delighted with. So this will hopefully be available soon. So blood flow restriction methods for muscle. Again, we want to determine their arterial occlusion pressure. And then from there, for the legs, we want to work between 40 to 80%. So for me, when I'm using it, if you went straight to 80%, they probably wouldn't come back to you in a hurry, just because it is pretty intense and painful. So the way I use it, I'll determine their arterial occlusion pressure, and then I'll halve it. A, it's easy maths, but B, 50% arterial occlusion pressure is just really comfortable for most people. And then from there, you can either progress it by increasing the pressure or increasing the intensity of the exercise as well. And another quick pointer for resistance training, you want to follow a rep scheme, traditionally a 30, 15, 15, 15. But I use the first set to dictate how hard the exercise is. So if they can only manage, because you're aiming for 30, if they can only manage 10, then you want to make it easier. And if they can only manage 50, you want to make it harder, etc. That's how I use it. So how can we optimize muscle healing using electrical stimulation and BFR? So immobilized immediately after injury. Here we can apply electrical stim passively from day 0. Aims are reducing edema formation, neuromuscular inhibition, and preventing atrophy. Whether this is going to be combined with BFR straight away in the future, we're going to be investigating. But currently, I just apply electrical stim on its own. However, when reducing edema is not a treatment goal of myself, that's when I will combine them both together. Next, we have blood flow restriction with aerobic exercise, so walking and cycling. Here, we're looking at increasing VO2 max, muscle strength, muscle size. And then finally, blood flow restriction with resistance exercise. So this is isometric, concentric, eccentric, all at low intensities. Aims are increasing muscle mass, muscle strength. We can have acute reductions in pain and hopefully get reductions in eccentric contraction associated damage. A little caveat is if you're looking for a cross-education strength effect, then going heavy without BFR is more effective. So, got one more slide after this. So this is my updated police paradigm for acute injury management. So P, protection still, immobilise first 2 days. Optimal loading, here we can combine blood flow restriction with aerobic exercise, resistance exercise, electrical stimulation to enhance muscle adaptation, and we can train the contralateral limb heavy. Ice and compression for pain and bleeding control, especially within the first 2 days. And instead of elevation, I'm going to put in electrotherapy. So here we can apply electrical stimulation straight away. Aims are reducing edema, preventing inhibition, and we can prevent atrophy. So thank you very much for listening.